Okay, it's sharply 1:30, so let's get started. And thanks for each one of you who are here in our breakout room. This session is on data integration and sharing in imaging and pharmacogenetics. And I'll be talking about innovations in multimodal imaging data and the integration and sharing, followed by Dr. Amy Pasternak, who'll be talking about pharmacogenetics into daily practice. My work on multimodal imaging has consistently mainly on integrating for some specific applications both imaging data, clinical and biological data with different imaging modalities in dentistry. And these involve a wonderful group inclusive in the bioinformatics in computational medicine department, in some important collaborators that we're very grateful for. Let me just see, because I see my part of my slides covered here. Let me hide these controls. And an interesting article came up in January 2023 in Science regarding a key problem that we have in dentistry, particularly in dental, oral, and craniofacial research regarding the availability of the data. Why are we going to share this data? How are the policies changing? How can we comply? And how about sensitive data that is difficult to share? I don't have the answer to many of those questions, but in fact, the National Institutes of Dental and Craniofacial Research is putting out a survey regarding this strategic planning for infrastructure in resources for data science research and research training in dental, oral, and craniofacial research. And there will be more information available during the AADOCR meeting this upcoming March. So this survey will be out soon. Commercial companies in one of the breakout rooms has a representative of Overjet as one of the commercial companies that is investing highly in the imaging solutions in dentistry. They have an enormous amount of data, but AI is wrestling with a replication crisis in which tech giants or commercial companies dominate the research, but the line between real breakthrough and product showcase can be fuzzy. And some scientists have had enough. Dr. Athey, who's here in the breakout room, used to say that commercial companies, they really have the ways of doing it. In academic life, we lag a little bit behind, but we try to do it the best that we can, following all of the requirements that are needed from NIH in our institutions. And interestingly, a lot of the work in imaging multimodality integration is being funded currently for the National Institutes of Cancer for cancer research, but NIDCR is lagging behind. But NCI and the Imaging Data Commons for Cancer actually has a different model where they do not have these central data repositories, right? They have a decentralized data federation, and this is the model that is already funded for cancer research, where you develop machine learning models or AI models, and then you share these models with each of the institutions so that then they can use their data and they can share back the models instead of sharing their own data. In the centralized workflow, as we are doing our best to perform in dentistry, the questions of data anonymization and curation in a safe and fair data way before sharing is crucial. And to employ learning health system approaches as part of the NIDCR strategic plan, we have all of these different types of dental records. And as Dr. Tabak mentioned, there are the healthcare data ecosystems, but all of us doesn't have any imaging data. The Biobank from England has MRIs and just small dental x-rays. FaceBase has a database of mainly animal data, genetic data, and the imaging data consists at this point mostly 3D photographs and animals micro CTs, even though FaceBase is open for all different types of imaging data in dentistry, but even the FaceBase infrastructure is going to have to be further supported as we move into new data management and sharing standards. An interesting review of automated diagnosis and treatment planning, for example, in the field of orthodontics was recently reported. But how we are really going to analyze these different images with machine learning approaches that can be generalizable, it still remains to be seen to be able to integrate all of the patient records. And of course, we also have, as part of our breakout rooms here, a breakout in the Big Mouth data, the repository that focus mostly on EHR clinical data. In the work that I do, focus mostly on computing resources and tools that are open source and developed in a web system that we now call the Smart Doc. Again, focusing on utilizing the recommended standardized dental, oral, and craniofacial ontologies by the FaceBase initiative. And I had asked Dr. Friedman to include the citation from his very innovative concepts that are the basis of the Learning Health System platform and his work that was published in 2017 towards embraced uncertainty during our discoveries for continuity in multi-stakeholder learning communities with an infrastructure that enables scalability. So we designed these imaging integration tools. We are testing their implementation, evaluating their results, also following this work already described back in 2012 on how to implement this learning health system that is very important before these tools can be disseminated and then provide further information for continuous updates. And the key stakeholders are not only clinicians, but clinicians that works with data scientists to establish these applications that is then able to integrate clinical exam, images, environmental information, as well as biological and genetic factors. And as Amy is going to be talking to you later, of course, in the real world data will encompass even many more types of different data that are needed so that we can get to the part of really reviewing the drugs that are used to treat each disease. And in our work in infrastructure for imaging data management and shared, we have developed an open source infrastructure that is called the Smart Doc, and Doc is for dental, oral, and craniofacial. And we have deployed and distributed imaging algorithms, as well as worked with federated learning in the distribution of these services. These are some of our currently developers working on these image analysis tools. We have recently established the collaborator in the biomedical computing department with Dr. Rao, and the results of his students are not yet as part of this publications, but we're very excited with this collaborative work too. But for our current papers that are included in this 15 minutes presentation, they are part of integrative risk predictors of in a specific condition of the temporomandibular joints in patients that present osteoarthritis of this joint. Do these technologies and these advances in imaging in clinical and biological information help us precisely classify, prevent, and treat TMJs? Our first paper was published back in 2020 on this work and tested the use of 15 markers of clinical imaging and biomolecular data in terms of disease classification and diagnosis at baseline. And the work done with another group from the University of Michigan, led by Dr. Najarian and Suresh Mehr, if biological data is not the standard imaging, type of data that is acquired for these patients with temporomandibular joint disorders, and we only have imaging and clinical data available, how do we improve diagnosis for these patients utilizing privileged information? And this work was published in MACI 2021. And we tested in these machine learning models a number of different approaches. Here describing the work that was presented in MACI in 2021, based on our preliminary data for this sample that was formed of only 92 subjects with the challenges of recruiting patients during the pandemic. Some of the candidate markers that had important contribution for the disease diagnosis will be further tested, as one of our PhD students has just finishing collection of 160 subjects. So we're now able to increase the data set for which we collect both biological, clinical, and imaging data for a more precise and accurate diagnosis. And these tools, both TMJ-OAI and TMJ-PI, are now deployed as a Docker container in a cloud-based system called the Smart Doc that is open, and anybody can create an account. And they will also be deployed in the Harvard open source platform known as 3D Slicer, which include then links for TMJ-OAI. These code can be trained or retrained with additional data, as well as if you don't have biological data and you only have imaging data, you can use our biological data sets just in the training part, but not for classification. The work in our aim-2 to evaluate the longitudinal data of these patients, we already have some preliminary data that will be evaluated during the AAOD OCR in the second part of March, and our PhD student is a finalist during these presentations. And we're very excited actually to have found that a combination of these imaging and clinical markers do play an important role to predict subjects at risk for more severe or improved prognosis of the disease, that we hope to be able to be sharing the results of this work in the future, as hopefully Najla gets her paper accepted. But yes, as we integrate all of this patient data, it's important that we remember that vision begins with the eyes, but truly takes place in the brain. And if we're talking about utilizing data science approaches for clinical decision support systems in dentistry, I would just like in the last 3 minutes to talk about some of our current work in progress. And this is a proposal that has recently been submitted. And you can see here the cycle proposed by learning health systems of discovery, continuity, and infrastructure that is the heart of our smart dental oral and craniofacial cloud-based system, combining different types of image analysis of digital dental models and cone-beam CTs and machine learning approaches with the specific applications for patients with craniofacial clefts, root canal abnormalities, and tooth movements in when the teeth are in critical positions. All of the tools to be shared in this integration are also developed as module of the Slicer computing platform, as Slicer has played a big role in our dissemination efforts of these approaches. And this is just a short overview of our website for storage, computation, and integration, where we make an effort to have our data that is shared follow the FAIR principles and the NIH data management and sharing policy. And just an overview here of the tools, as I said, when you can click and have access in this secure web-based platform. The network of collaborative institutions in our team now includes 52 countries with over 500,000 downloads of the open source toolkits that we have been working on. This is our publication in 2022 here for a patient with craniofacial cleft with automated segmentation of multi-anatomic structures in cone beam CT. Last week in our dental research, we presented on the automatization of the tools in the slicers, from data anonymization to orientation, merging of different imaging modalities, quantitative measurements and registrations, and work of some of our developers, as well as clinical applications in cleft patients, tooth movement, and surgical outcomes stability. And we have recently also have had work accepted for publication on caries research, led by Mara Bowaka from Egypt, a preliminary work on dentin regeneration and tooth lengthening. The code is publicly available in GitHub in our DCBIA OrthoLab site. And currently in 2023, this is where we are. We get the images from our scanners in the dental schools. We make sure they are anonymized, utilize them in the automated platforms. And we do work with our team of radiologists and clinicians experts to make sure that the quality of our quantitative reports are adequate. We hope that in 2023 and 24, we will be at the point that we are able to integrate EPIC as our imaging informatics in the dental school is working for setting up together with the medical school of the Wisdom version that will then give us access of all of the imaging modalities that we have in dentistry. At this point, AI is not smarter than clinicians, but it aids clinicians to be smarter. And this is some information for those of you that are interested in starting collaborating. And sorry that I kind of rushed a little bit to make sure that I covered the content. I think we have time for 1 or 2 questions before Amy starts her part. Do we have any questions?
Lucia, this is Brian. Hi. Thank you for giving such a lovely talk, and congratulations on your progress. I guess let me just ask you, from your perspective, with all this new stuff kind of popping up on you, and all popping up on all of us, I mean, what do you see as the biggest challenge for your work right now?
Well, as I tried to ask Dr. Tabak, and I think it's interesting, it's really, and I have had a chance to serve on a data science working group. Yes, we have these requirements for data sharing, but the infrastructure is really not there yet. Yeah. So yes, and yeah, the data may be the new oil, but if we don't have the proper curation of this data, and the algorithms are not trained properly, we have been facing over the last month that I'm pretty sure everybody's facing the craziness with the Chat GPT and Google Bard just exploding, and people questioning who's going to be the current leader in search. And so information comes, but of course Google has a much larger database. You can have the algorithms, but if you have the data too, how do you make proper use of this data? So even in our collaborations with wonderful researchers in your department, Brian, both Kayvon and Arvin now, sometimes our data sets are not so large because we want to collect data prospectively. And some of the collaborations that we have done with other centers, and even like we are starting some collaborative works with Dr. Da Silva, who is leading this organization. If you don't focus specifically on a clinical condition, if you just get the data from the electronic health records, what is the quality of this data? So, and IDCR is encouraging at this point people to share and deposit their data at the face base. And I'm glad that I work with sharing the tools. And of course, if our data needs to be shared and deposited someplace, we'll gladly share it. But how this data is going to be used, I think it's a big challenge for the years to come. But thank you for asking. Thank you so much.
Yeah, thanks. It all makes sense. Maybe go to pharmacogenomics.
Yes. Amy, are you ready?
Sure, I just wanted to make sure there wasn't another question.
There is one.
Okay, yes,
Here.
Tomar.
Yeah, hi, Lucia. Thank you very much. I really enjoyed your talk. So we see a lot of different types of data. So the imaging data, which is on the way to trying to be better than clinicians, and there is records, and there is gene and transcription. There are different types of data that I think that in all of each one of them separately, we know kind of how to handle data science. But are there any thoughts, strategies for generalizing? Because all of this can provide a lot of information on the same person, but do we actually know how to put all of these together?
So in the work that we have done, we have worked with a group of statisticians to test these models together and test not just correlations, but like in our recent work for prediction of disease progression, they basically do some very complex feature selection approaches from biology information, from clinical information, and from management information, and test the contribution of each of these factors in terms of the model. For genetic data, just because the amount of data is so much larger, I don't have experience with genetic data myself. So maybe Amy has, and she can talk more, and we can go back and revisit your question at the end, if you don't mind.
Thank you very much.
Thanks.
Hi, Dr. Cevidanes. This is Elan, who's going to Michigan for ortho pretty soon. So now, hi. So nowadays, because everyone is doing some sort of big data or imaging analysis in the field of ortho, what do you think makes you special on this topic?
I'm not so sure anymore if I'm special anymore, because there's so many younger and brighter people, but we keep trying our best and staying. If you look at the commercial companies, they are having tons of data, right? And I mentioned this briefly in the beginning of the presentation. But I think maybe what the work that we do is special because we work with open source data development and trying to make sure that the quality of our data, that we're testing the quality of our data, but without the pretension to making me special, because I don't want to pretend that I am that special, but look forward to working with you, Ilan. Thanks for asking. Amy, please.
Thank you so much.
Thank you.
Okay, can you see my slides okay?
Yes.
Thanks. Good afternoon, everyone. I'm excited to have the opportunity to wrap up this session today. I'm going to come at this from a slightly different perspective. I work with genetic data, but my work has really focused on how do we take sort of those big data elements and really bring them down to the patient level and make sure that we have data to act on when we see a patient, but also really think about how do we take this data and make sure that it's available for multidisciplinary use. And I want to use a couple of examples to highlight why we really think that that is important, as with pharmacogenomics as an example. So just in general, we know that not all individuals are going to have the same response when we give them the exact same medication for the same indication. Some of our patients may experience side effects, and others, seem to have no treatment efficacy associated with giving them that medication that will often work for others. And so when we think about genetic variation in pharmacogenomics, that can be one piece that can help us understand some of that inter-individual variability. And there's lots of different examples of pharmacogenomics, but the kind that we sort of have the best understanding of at this point is differences in patients' ability to metabolize different medications. If they have a genetic variation that alters their metabolism of a certain enzyme, they may have an altered exposure to that agent, which can modify their risk for adverse events or response. And so in this example, we maybe have 3 patients. The one indicated by the black line has no genetic variation, has normal activity. And when we give them a dose of a medication, that exposure to that medication is what we would consider safe and effective. But if they have altered activity, either in the red or the blue, they may go over that safe window and be at risk for toxicity, or under that safe window and be at risk for treatment and efficacy. And so we really are trying to start to understand and integrate this at a point of care perspective to say, when we know a patient has a genetic component, we can modify their treatment to really improve outcomes overall. And so one specific example, which I'm sure is relevant to many individuals, but I think dental school in particular, in terms of pain therapy treatment, is opioid therapies and the pharmacogenomics of opioid therapies. And really the best established one we have is opioids and the drug metabolizing enzyme CYP2D6. This enzyme has extensive genetic variation, which really results in a highly variable spectrum of activity. Some patients have incredibly active enzymes that will break down or activate drugs very, very quickly, and some patients have almost no activity in this enzyme, which can cause a lot of variability in response. So in particular, CYP2D6 is really important in the activation of different opioid therapies, and codeine and tramadol are two of the primary ones where this enzyme really is critical to having an analgesic effect. And so when we have patients who are ultra-rapid metabolizers of this enzyme, if we give them a dose of codeine, they're going to convert that medication into its active form of morphine much, much more efficiently than someone else. And there actually have been case reports, unfortunately, multiple case reports of extremely severe or even life-threatening toxicity associated with death of the patient or death of a neonate who was being breastfed by a mother, based on simply giving this medication, which is very commonly prescribed, to a patient with ultra-rapid metabolism. And so this is where we sort of come in and think about how can we take that big data level of genetics and apply it to a scenario to improve that specific patient outcome. Before we look at that specifically, I want to walk through kind of some of the considerations we think about when we're actually thinking about translating this into practice. Are we ready to move a research-based association into a patient care decision? And there's a couple of things that we will often think about. One of the first one is the analytic validity of the test. Genetic data is increasingly available to anyone. You can go online and purchase a DNA kit to have your DNA analyzed, but not every single one of those tests has necessarily been validated to the level where we really trust the accuracy of that data. And so acting on potentially a direct-to-consumer report might not be a reliable source of information. So I think that's a part of considering for translation and talking with patients and pulling that data into our medical record. We also need to think about the clinical validity and utility of the results in terms of how confident are we that this genetic finding really is truly associated with a specific medication outcome before we start using it to guide that medication outcome. And then do we have good evidence to say that we can prevent the risk of toxicity or improving the efficacy of treatment using that result? And then, of course, always important is the ethical, legal, and social implications of those results. Most of the pharmacogenetics we work with on a day-to-day basis in terms of drug metabolizing enzymes have, I would say, less implications in this area because they're typically not diagnostic and they don't necessarily have impact on family members. But when we think about big genetic data, that's certainly a major aspect of consideration for moving this information into patient care. One of the primary resources we really utilize to help look at the criteria for this translation are the Clinical Pharmacogenetic Implementation Consortium guidelines. These really help guide how to apply genetic results when they are available, but they're not readily integrated into a lot of different systems or considerations. And so I think a major challenge we face right now is how do we integrate this into our systems in the day-to-day. Just quickly, some examples of different current existing guidelines, both opioid medications as well as NSAID medications currently have actionable pharmacogenetic recommendations, meaning we could personalize therapy for those individuals when we know their genetics based on those results. And for the sake of time, I'm going to skip over this slide, but just some information about how for certain genes, we have very clear recommendations of how we can modify treatment. And for other genes, there might still be under investigation, but we don't yet know whether something is truly clinically valid or clinically actionable in terms of improving outcomes for patients. So what are the challenges we have to integrating pharmacogenomics? We have lots of data available. Increasingly, patients are seeking out this information. There's guidelines for how to apply this data. There's FDA recommendations around testing and application of results. There's an increased number of clinical or commercial laboratories that are offering pharmacogenetic testing to patients. And over the last couple of years, an increase in the number of insurance companies that are covering this testing. But we're still not routinely seeing it integrated into daily practice. And some of those challenges may simply be the visibility of the result. We have lots of patients here at Michigan Medicine who have had pharmacogenetic testing, but it's not always easily visible. If we have an external laboratory who has processed that report, they give these awesome, very nice interpretations and pages, but they're often sent over as a PDF, which we know in clinical practice can be very, very hard to work with or identify, even if you're the provider that ordered that testing. There have also been numerous surveys that have identified that providers really often do not feel comfortable interpreting or applying this information. And I think one of the key things that I really wanted to highlight here is the potential for the multidisciplinary interpretation of these results. I would say the highest population where we see clinical pharmacogenetic testing being performed is really associated with psychotropic prescribing. So our antidepressant therapies or mood stabilizing therapies, those have very clear guidance and really great laboratories that offer testing focusing on those medications. But when we think about drug metabolism, the same enzyme that breaks down an antidepressant also breaks down different pain medications and may also break down other antiemetics. And so we may have application for these results beyond what was the intended use of the original pharmacogenetic test order. And so that's really where we've been focusing on how do we integrate and increase the visibility of these results so that all providers who see these patients, regardless of specialty or discipline, can be made aware of this potentially impactful result, even if they didn't know about the pharmacogenetic test result ordered to begin with. And so I would just want to highlight a couple of strategies that we've taken here at Michigan Medicine. We are in the sort of early stages of processing this. There's lots of great examples of other institutions that have done this as well, but I'm hoping that this will really help providers and patients feel more comfortable with applying this data. Really, our primary focus initially has been increasing the visibility of these results. And it sounds very simple, but simply documenting the test order in the EMR. A lot of these are ordered through laboratories that have portal ordering systems, and they weren't being captured internally. And this now allows us to have a tracking system to identify which patients have results. But I think even more importantly is making sure that we have result documentation in a discrete format in a way that we can access and utilize and apply that data. So again, there's different reports from different laboratories, but they'll often give a medication sort of interpretation and help classify and understand the severity of the interaction between the gene and the drug with color coding. And this can be really, really helpful at the point of that result being returned. But if another clinician doesn't know about that test result, or again, the result or report was specific to a certain disease state, that doesn't necessarily translate to other ways to apply that result. And so we've worked really closely with the Precision Health Initiative, Pathology, and HITS to implement ways in our medical record to discreetly store this pharmacogenetic data in a non-discipline specific manner so that it can be applied collectively across our entire healthcare system for any medications where this information might be relevant. And so that section of the medical record is called genomic indicators. And so once we have discrete information captured in the medical record, that really allows us to develop and deploy clinical decision support strategies to identify in real time pharmacogenetic interventions that can be made to have immediate impact on that patient safety, but a broader impact at the healthcare level to improve overall prescribing decisions. And so our objectives of our currently developed clinical decision support have been to help identify patients who require testing, capture any high-risk pre-existing results prior to that medication ever being prescribed, and then also to try to help prevent duplicate testing, because as genetic results, these have implications across the patient's lifetime and often don't need to be repeated. So just a quick example, we do have some instances of where there are clear FDA recommendations around getting testing or recommending that you obtain pharmacogenetic testing prior to a prescription. And so we're able to query with the storage of that genetic result whether or not the patient has that data available to them and provide a recommendation to the clinician related to ordering the testing. But I think even more important, and something that's going to continue to emerge as part of practice, and I really liked the comments earlier about becoming accustomed to having this data available, is we are going to have patients who have pharmacogenetic data in their medical record, and we need to make sure that we're leveraging that, not only in terms of learning new things about pharmacogenetics, but impacting that patient's care. And so we are continuously working to develop clinical decision support to identify pre-existing results that could be used to guide prescription therapies. So the example I have here is now in our medical record, we're just launching these alerts, but every time a codeine prescription is written in our EMR, the system will query for whether or not that patient has a CYP2D6 phenotype result. And if that result is found to be an ultra-rapid metabolizer, the clinician will be notified of that potential risk for toxicity for that individual and provide a recommendation around potentially considering alternative therapies. And so this is something that we are continuously doing with different drug gene pairs, again, applying results beyond their necessarily intended use for their initial prescription. So this has taken a lot of work, and I think it's a little bit more of a patient level, but I think it ties into the big data concerns of, making sure that we have a way to capture all of the data, but also, identify what data is actionable and what data is maybe still investigational, but leveraging that to continue to learn more about how to apply genetics in patient care, how genetics interfaces with other components of patient care. And then maintaining, as we learn more up-to-date recommendations in our system, but then also continuing to focus on provider education and really helping with that culture change or paradigm shift in terms of things that we think about or things that we can act on when we're prescribing medications to patients. So I just want to, make an acknowledgement to all of the different groups, lots and lots of different individuals in these different departments who have made this sort of translation from a theoretical or a clinical aspect into something that's now being routinely integrated into day-to-day prescribing in our patient care. So I think we have a couple of minutes in case there's any questions. And I believe the recording will be sent out as well as a post session evaluation survey if you are willing to fill that out.
So Amy, in talking about your databases, where is your database from? Is it just internal from the university?
So it's, so it's all of the clinical testing that's being ordered through MyChart currently is the data that we are pulling from. So we also have some instances of,
right?
I'm sorry, say that again.
Comes from the EPIC system in the
So it's from the EPIC system. We also have instances of patients who have been tested at outside institutions who are bringing in their clinical test results from external providers as well. So it's sort of a mix of sources.
Mm-hmm. How was it having access to the EPIC data? How did it work for you? Data sets.
So there's definitely challenges. I don't think that the new genomic indicators feature is designed specifically for genetic data, but prior to having that system, the medical record really wasn't designed for genetic data and capturing that. And there's differences in interpreting different types of genetic data as well. So we're definitely figuring it out in terms of trying to capture that as meaningfully as possible. But there's challenges for sure.
Can I ask a question?
Sure.
My name's Callie. I'm a 6-year PhD student in the genetics and genomics program, and have a basic science background, so lacking on the clinical side of things. So I have 2 questions actually. My first question is what would be an indication for genetic screening, right? Because in my head, you kind of don't know how someone's going to respond to a drug until they respond to a drug, right? So, and then it seems like it's almost too late for your pharmacogenomic testing. So I guess what would be the indication for testing prior to all of this? Right?
Yeah, so in a few instances, we have FDA recommendations saying this patient needs to be screened for this genetic marker prior to starting this medication. That's rare. Most of the time it's it's very frequently patient initiated in terms of their interest in understanding. The other kind of commonplace is if patients have failed multiple lines of therapy, particularly if they've tried multiple antidepressants and still are not maintaining, then there may be better insurance coverage to obtain that testing. So I would say it's highly variable, but most commonly it's based on a known medication need or a prior non-response to a medication.
Thank you. My second question was, I have another follow-up question to that, but I'm going to go with the second question first. Regarding provider education. So it makes sense, right, to, you know, in a chart to present this information in a non-discipline specific format. That makes sense to me, but how, like, it's my understanding that provider education is a huge kind of roadblock to applying genetic data to clinical care. And what do you see as a solution to that?
Yeah, that's a great question. And I think our spin on that from a pharmacy perspective has been to make it less about the genetics and more about explaining that this is a risk associated with an adverse event or an ineffective therapy. Very common in our field is looking at drug-drug interactions and the potential for one drug to interact with another drug, and you would avoid using those together. And so we've really tried to leverage that sort of concept as the way that we facilitate that education, even in those real-time alerts of this is the risk, this is, you know, what the recommendation is to not do that, and not really get into the specifics of the genetics of the patient, because I'm not sure that that impacts the outcome of overall.
In talking about genetics data, since Tomar had a question, even EPIC does not have genetic data as part of the EPIC database, right? It's not.
So the new genomics indicator module, which Precision Health Initiative helped to launch this fall, does now have that capability. So we should increasingly be able to capture genetic data as part of the EPIC system. There are some challenges in terms of interfacing with laboratories and capturing that data, but it is a very new feature that we are hoping to be able to utilize.
You see, Tomer, you can start exploring those integration of this genetic data that apparently I didn't even know because I don't work with it, but we're learning together here, right?
Yes.
Amy, what would you say in your very innovative studies in pharmacogenetics have been your biggest barriers for having these studies set up and your challenges?
I think capturing the data really has been the biggest challenge that we've had, knowing that clinical data can come from a variety of sources. I think the challenge that we are going to be facing, even though we now have somewhat of a solution to that, is again, sharing that data more broadly. So if a patient is seen at other institutions, making sure that that data is visible through the Care Everywhere systems, or making sure that the patient can be their own advocate and having a way to communicate that information to other providers is going to be a big challenge as we continue to move forward.
Yeah, one of the things that we have seen is that the part of the new data management and sharing plan, they are encouraging that future patients' consents patients need to give permission for broad data sharing, which I don't know, is that a reality in the School of Medicine consent? I don't think it's a reality at the School of Dentistry yet.
I'm not sure. I'm not sure overall.
Because even from a patient perspective, even if it's de-identified data, you know, if consent is required, review of all of the patient consenting would probably need to be thought of. But it's already hard to capture the data. Let's not come up with more obstacles. But well, any more questions, everybody here in the breakout room?
Hi, Amy. My name is Yanjie. I am second-year dental student. I am very I find your presentation very interesting. Could I ask a question about how useful has those pharmacogenetics in the clinical in the usage of clinical settings? The reason I want to ask this question because I was involved in some trying to create some prediction models in clinical usage before. However, when we try to apply those prediction models in the real cases, the ability of those predictors, like the ability of using those predictors to predict outcomes is always a problem. I just wonder how useful is it, like for apply those pharmacogenetics in the clinical setting. What are the pros and cons in terms of apply it?
Yeah, it's a great question, and one that I don't have a great answer to yet because we are really just truly launching this in our patient care system. So we're hoping to be able to have that data here as we continue to track how these alerts are functioning and what patients have data. I can say that when we look at, if we use the guidelines that I referenced, the CPIC guidelines as a resource for drug gene pairs that have well-validated impacts on medication outcomes, either side effects or treatment efficacy. We just did a survey study a query of the MGI database here at Michigan Medicine, and we were able to identify that in the realm of 30 to 60% of patients were expected to have experienced at least one drug gene interaction in their time here at Michigan Medicine. And so there's a lot of variability, and the number is broad based on how you kind of apply those definitions, but we would expect a large proportion, and the VA has done similar studies of, in the realm of 30 to 50% of patients could be impacted by this in some way related to their medication. The association between the outcome and the medication and the gene can vary based on treatment type. So there's some cancer therapies where we can guarantee patients will have very, very toxic side effects based on their genetics. Whereas antidepressant therapy, we know genetics can play a role, but it's certainly not the only contributor to how a patient responds to treatment. And so that part is a little bit more challenging to tease out and can vary discipline to discipline. But we're hoping with the integration of this information, we'll be able to try to answer some of those questions more thoroughly.
Got it. Thank you.
That is very exciting, even from the dentistry perspective of facial pain. We are certainly very much look forward, right, Tomer, to this setup, but at Dentistry, we are limited until we are part of EPIC, and this integration with the university health records is implemented for us. We are hoping to have some launch in October of this year, but with all of the hurdles, it might be sometime middle of 2024, but hopefully definitely happening over the next couple of years. Everybody, we've gone 2 minutes over. Thank you so much, Amy, for the wonderful second part, and thanks for being here for the first part with me too. Have a good afternoon. Thanks. Bye-bye.
Thanks, everyone.